Next panel over here in the speakers area, so if you'd like to join, this next topic is the endocannabinoid system. And I am Dr. Dustin Sulak. I'm a local osteopathic physician. I'm a general practitioner. We're going to start by introducing myself a little bit and laying some of the groundwork of the endocannabinoid system, and then we'll turn it over to our two esteemed speakers to answer some of my tough questions about how this is relating to the work that they do. So just a little background about myself for those of you that didn't hear this earlier. I started practicing in Maine in 2009. I came up here for residency to the Family Medical Institute in Augusta and opened a small practice in Hallowell. At the same time that our medical cannabis here, the law expanded significantly, and there were really only a couple other doctors in the state willing to sign off on certificates. So I feel like cannabis chose me. I didn't necessarily choose it, but it has been such an incredible ride to hear from thousands of patients that have been using cannabis already, and now moving forward in time to today where there's thousands of patients that have never tried cannabis before in their lives that are coming into our clinics asking for an alternative to the conventional treatment that's more toxic, more dangerous, and less effective than what we're doing here. And so the reason why cannabis works so well is going to be covered in this next 20 minutes. And I think this is a really interesting and important topic. It's something that a lot of us hopefully have had the chance to feel curious about. So here's if you can see the screens, here's a partial list of health conditions for which there's some human evidence that cannabis is an effective treatment. And this list is ridiculous. How can you see a list with one agent being able to treat psychiatric conditions like addiction, inflammatory conditions like fibromyalgia, gastrointestinal conditions like Crohn's and ulcerative colitis, infectious conditions like antibiotic-resistant strep or MRSA, multiple sclerosis, all sorts of neurologic conditions, little things like headaches and menstrual cramps, big things like ALS or Lou Gehrig's disease. So this is a very important question. How or why is it possible that one herb can treat so many different conditions? And this important question has actually led to a major discovery for the history of medicine, for the history of humanity. This question has been asked for decades by researchers, and the answer is the endocannabinoid system, which was discovered and proven definitively in the early 90s. And so if we look at a PubMed search, PubMed is a search engine that gives us results for peer-reviewed journals. These are all scientific articles. In 1993, there were 10 citations for the word endocannabinoid. This year, 8,000. That means that in the last 20 years, on average, there's been about one peer-reviewed article every other day for 20 years. And it hasn't been spread out like that. That's the average. Really, nowadays, there's several articles each day published on this topic. There's a huge explosion of research in this area, and there's a very good reason for it. This physiologic system, the endocannabinoid system, is an incredibly promising target for therapeutics, for treating all of these different conditions. The endocannabinoid system produces molecules in our body that are called endocannabinoids that function very similarly to THC and some of the other compounds in cannabis. And the question is, why are we making these molecules? Why do we make these substances? The answer is to respond to cellular stress. It's the same answer in the brain as it is in the liver, as it is in the muscle, the bone, the connective tissue, all over the body. We're producing these compounds as a response to cellular stress, whether that's caused by an injury or by an infection or any other type of metabolic dysfunction. We are making endocannabinoids to respond to that stress and to return ourselves to a state of balance or homeostasis. So let's take a quick look at some of the basic components of the system. First, we have the cannabinoid receptors. These are cell membrane receptors that sit at the outer surface of the cell. So you could think of this as the cell membrane. Here we have, I'm not sure if you can see my mouse on the screen, maybe not. We have below that gray line the inner domain of the cell, and above that gray line what we call the extracellular space. And these receptors that are pictured here, these are like antenna. They're a way for cells to communicate with each other. So a cell might say, hey, you need to stop what you're doing, or you need to do more of what you're doing, or you need to start getting into rhythm with the cells around you. All of these very important physiologic functions are controlled by these types of receptors, including the cannabinoid receptors. Now, I like to go a little deeper than the cartoon images. So here's what it looks like in real life. These are cells. As you notice, they're not shaped like circles like you see in the diagram, but more like tents. They're these kind of oblong connective tissue cells. In blue, we have the nucleus. In bright green, we have cannabinoid receptors. So you can see these little antennae are all over the surface of most cell types in the body. And if you look at the human brain, here we have the brain lit up showing the density of cannabinoid receptors. These receptors are everywhere in the brain. There's more cannabinoid receptors in the human brain than there are any other type of neurotransmitter. So more than serotonin, more than dopamine, more than GABA or glutamate. These receptors are truly everywhere in the brain, and not just in the brain, but also in the human body. You can see here an image of cannabinoid receptors lighting up. The more bright colors are the highest density, so you can see a lot of receptors in the liver. You can see them in the lymphatic system, in the bones, in the cartilage, in the connective tissue. I mean, we are really laden with this system of communication. We have these little antennae all over the body, and I think now you're starting to get the picture of why the same substance could help with a neurologic condition or a gastrointestinal condition or a skin condition, because it's the same language being spoken by all of these cells, and that's a cannabinoid language. Now, this is a very old system. This is nothing new to animal physiology. In fact, some very basic creatures have cannabinoid receptors that are almost exactly the same as what we have as a human in our body. So you can see up on the screen we have the sea squirt and the fugu fish. I mean, a sea squirt is an incredibly simple organism. Their cannabinoid receptor being the same, almost exactly identical to what we have in our brain, that tells us that this is a very important system. Evolution wouldn't have conserved these receptors over 600 million years if they weren't doing something very important in the body. This is very important. They're being selected for, protected, and preserved throughout evolution because they're doing something that's just so crucial to life, but maybe not to all life. Insects are the example. They seem not to have cannabinoid receptors, and that may explain their lack of a sense of humor. Now you guys all have that though. Now here we have the endogenous cannabinoid ligands. These are the molecules that our body produces to fit into these receptors, right? The sea squirts and the fugu fish don't have receptors because they're going out and acquiring cannabis and using it. They're, like us, they're also making cannabinoid compounds that are signals that fit into these receptors or that stimulate these antennae. And these are just the two that we know the most about, anandamide and 2-arachidonylglycerol, or 2-AG. But there's several endocannabinoids, more and more that we're learning about all the time, that interact with the cannabinoid receptors and also overlap with other systems. But we are making these compounds, again, all over our body, to the point where we have two of the most well-known researchers at the National Institutes of Health, Paul Patcher and George Kunos, in their 2013 article, I'm going to quote, because these are not cannabis proponents, these are mainstream scientists that are really looking at a broad spectrum of issues that affect public health. They're concluding that modulating endocannabinoid system activity may have therapeutic potential in almost all diseases affecting humans, including obesity, metabolic syndrome, diabetes and diabetic complications, pain, neurodegenerative, inflammatory, cardiovascular, liver, gastrointestinal and skin diseases, psychiatric disorders, cachexia, which is wasting syndrome, cancer, and chemotherapy-induced nausea and vomiting, amongst many others. This is a major discovery for human health, a major discovery for the history of medicine. And as you can see here, we've known about it for 2 decades, yet it still has no place in medical school or nursing school curricula. Doctors and nurses are not learning about this physiologic system, even though it's probably one of the best targets for affecting human health in a positive way, and very specifically solving some of our biggest challenges that the healthcare system is having right now. Cannabis, Dr. Ethan Russo said, I might be paraphrasing, that cannabis is the therapeutic compass to the conditions for which conventional treatment has no effective solution. And that is absolutely the case. We find that the biggest letdowns in conventional medicine come over to cannabis and respond extremely well. So we are really set up to help so many people. We're hardwired to respond to this plant. Now these molecules that are in the cannabis plant, they're not there to get the plant high or to help the plant with its endocannabinoid system. The plant doesn't have an endocannabinoid system. These, just through a beautiful coincidence of nature and maybe some coevolution over maybe 40 million years, have a place in our medicine cabinets because these molecules in the plant interact with our cannabinoid receptors in ways that are very similar to the compounds that we produce. If you remember the molecular structure, they actually look quite different on paper, but they act in a very similar way at the level of our receptors. So here we have the phytocannabinoids, and again, cannabinoid receptors 600 million years old. The plant cannabis, maybe 40 million years old at most, probably closer to 34. So we've been using cannabinoids much longer than cannabis has. But here on this slide we have cannabidiol, or CBD, which has been getting a lot of attention. We're going to discuss that during today's talk. THC, which you all know of. CBG, or cannabigerol, this is a precursor cannabinoid that has some very exciting therapeutic properties. And then CBN, which is a breakdown product of THC, also very exciting. Now we have an ability to stimulate our endocannabinoid system using this plant. We can also stimulate it using non-pharmacologic means. For example, exercise. The runner's high is due at least in part to an endocannabinoid event that's happening in our brain. Meditation, sleep, stress reduction can increase our endocannabinoid levels, so there's many opportunities to do it without putting something in your body. But you can also influence the endocannabinoid system with pharmaceutical drugs. And many of you are probably surprised to learn that there's two that are approved by the FDA to be prescribed and used in this country. Dronabinol, which is simply synthetic THC. It's THC dissolved in sesame oil in a capsule. That's a Schedule III substance that any doctor with a DEA license or nurse practitioner can prescribe. Whereas THC that's not dissolved in a capsule and called dronabinol, that's Schedule I. That's way too dangerous to use even with your doctor's supervision. But if it's in a capsule and dispensed by a pharmacist, then it's Schedule III. We also have nabilone, which is a synthetic THC-like substance, also indicated for chemotherapy-induced nausea and vomiting. So many options. Before we turn it over to our panelists, I want to go through quickly the mechanisms of action. How are THC and CBD, the two most well-known cannabinoids, functioning in the body? And this is really just the tip of the iceberg. Almost anything that we have the ability to say up here today about the endocannabinoid system has to be an oversimplification, because there's a lot of unknowns still that need to be elucidated, and this system is just has an incredible complexity to it, like most living systems do. And we're starting to admit that in medicine. But in general, THC mimics your body's own endocannabinoids. So I mentioned anandamide and 2,8-G being produced in cells as these signaling molecules. THC really works almost the same way. It will stimulate the CB1 receptor and stimulate the CB2 receptor. It doesn't fully stimulate them, which is a good thing. Some of these dangerous synthetic cannabinoids that you find in head shops on products like Spice and K2, they're more full agonists, very strong effect, much more likely to cause adverse effects. Whereas THC is a partial agonist, so it comes along and it stimulates the receptor, but it doesn't overstimulate it. It's not heavy-handed on this very important physiologic system. It's kind of giving it a gentle nudge. So gentle that it can actually serve as an antagonist or a blocker to those receptors in certain circumstances. So for example, people who are obese have very high levels of endocannabinoid production because it's produced in the fatty cells of the body, to the extent where they may have too many circulating endocannabinoids and actually be shutting down their endocannabinoid system because it's been chronically overstimulated. In a scenario like that, THC could come along and do the opposite of what it tends to do in the rest of the cases. It could actually partially block those cannabinoid receptors, giving them a chance to reset themselves, upregulate again, and return to a normal level of function. So we have this beautiful dual role of THC where it tends to be stimulating with a little nudge, but if it needs to be blocking with a little nudge, it can do that as well. Now, THC and CBD work very well together. This is truly how nature gave them to us and how they shine when it comes to treating people. CBD tends to antagonize the undesirable effects of THC, such as intoxication, sedation, rapid heart rate, but it also enhances the benefits of THC, like pain relief, nausea relief, and the anti-cancer properties of THC. So you can see how they work so well together. And here's just a headline: even the munchies, you can even attenuate the munchies with that THC tends to produce with the help of CBD. So how does CBD work? A lot of people are wondering, well, if THC stimulates the CB1 and CB2 receptor, does CBD work in the same way? Does it block the receptors? Well, the answer is actually neither. A very strange circumstance here, where CBD has a very low affinity for these receptors. It doesn't stimulate them. It doesn't necessarily block them. But what it ends up doing is binding to the receptors at kind of a side door or back door and changing the way those receptors work. It tends to make them less sensitive to THC. So it's not blocking, but it's decreasing their sensitivity a little bit. And this is how it's able to achieve tempering some of these strong effects of THC. So when you administer them together, you get less of a strong THC effect, but you're able to still get that effect, but it's going to be more well-rounded and better tolerated. Now, CBD does not stop there. It is way bigger than just the CB1 and CB2 receptor effect. CBD is doing dozens of different things all over the body. It's antagonizing several receptors. This means it's blocking them, including one of the opioid receptors, the adrenergic alpha-1 receptor, while it's also stimulating certain receptors. That 5-HT1A receptor, that's the serotonin receptor. So CBD does have a pro-serotonin effect. And this is what most people feel when they're taking a low dose of it. It has nothing to do with your endocannabinoid receptors. People are feeling awake, alert, positive mood. This is typically a serotonin effect. Same with the vanilloid receptors. These are, that TRPV1 receptor is what capsaicin, the compound in hot chili peppers, stimulates. CBD is able to stimulate that same receptor. Now, people can use chili peppers for reducing pain and for psychiatric benefits and many other benefits. Well, CBD has that same benefit, but it doesn't burn. So that might be really nice. It's not painful, but you can still have some of those same benefits. It's also inhibiting the uptake of numerous neurotransmitters. So a lot of us think of typical antidepressants blocking the reuptake of serotonin. Well, CBD is also doing that, but not just with serotonin, with many of these other neurotransmitters, including our own endocannabinoid, anandamide. So it's raising levels of our endogenous cannabinoids, the ones that our inner pharmacy makes. It's blocking the breakdown of those cannabinoids. So it's influencing the mitochondrial energy production. CBD is doing so many things in the body. If this were a pharmaceutical, which it's becoming, surprisingly, it would be called a dirty drug, right? Most pharmaceuticals are designed to do one thing in the body. We like them better that way. We know what they're doing, and that's how the FDA likes things. This is simple, single molecule medicine, which I think has proven very sufficiently over the last 50 years to not serve our species that well. Single molecule medicine really doesn't work as well as plant-based medicine, where you see these so-called dirty compounds that have dozens of mechanisms of action in the body. And this can be worrisome, because if something's doing so much, then of course there's some potential for harm. But again, so surprisingly, the harm associated with CBD is almost nil. This was another report that summarized all the data, and they concluded, in general, the often described favorable safety profile of CBD in humans was confirmed and extended by the reviewed research. Most common adverse reported events: tiredness, diarrhea, and decreased appetite, maybe a little bit of weight loss. But you can use CBD at 5 milligrams, you can use it at 2 milligrams. Some people might feel something. You can take a 600 milligram dose like this, and most people would have no adverse effects or very minor ones. It is such an incredibly useful and incredibly forgiving gift from the cannabis plant. And again, it goes so well with THC. What I really don't like is when everybody starts saying CBD is the medical part, THC is the recreational part. Couldn't be further from the truth. The beauty is when you use them together. So I'm going to just take 1 or 2 more minutes to talk about using them together, and then we're going to hear about our panelists' experience with the endocannabinoid system. So this is a study that looked at a pharmaceutical preparation of cannabis in an oral spray. And some of the sprays had CBD and THC in equal parts, and some had just THC. And this was given to patients with cancer pain who were using opioids that didn't have enough pain relief with the opioids. They needed something else, so they added the cannabis. Some people got THC, some people got a combination of THC and CBD, and they were allowed over the course of 2 weeks to figure out what dose is right for them. And so that's what we have, if you can see the pointer. The bottom line here are the folks that were using only THC. And they were using about 10 sprays per day, which equals about 22 milligrams of THC per day. This middle line here is the group that was using both THC and CBD, and they were averaging closer to 12 sprays a day, but remember, there were equal parts, so altogether they were using about 50 milligrams of total cannabinoids, 25 or 22 of the THC plus 22 of the CBD, and they still averaged at a higher dose. So this is something that I want you to keep in mind. When you start adding CBD into the mix, the total number of milligrams tends to go up for people. And remember, that's okay. So this is how I put it in this schematic. If you're, say, treating pain, some people might get pain relief with 5 milligrams of THC. But if they're using a 1-to-1 ratio, maybe they'll need 8 or 10 milligrams of each, THC or CBD. But if they're trying to treat that pain with CBD alone, they're probably going to need even more, maybe 20 milligrams, maybe 50, maybe 100. So the beauty is in the synergy here. Some people suggest that high doses of CBD can be sedating. We know that low doses can be awakening. I'm going to be curious to hear what the panelists say about that, but we suspect that the sedating effect is not from the CBD, but is from some of the other compounds that come with CBD, because a lot of these CBD dominant strains may also have other sedating compounds in them. So that's, I'm going to pause there and introduce my speakers. We have Lynn Mathre from Patients Out of Time. So Lynn is a nurse, Navy veteran. She has been working tirelessly for 20 years to bring cannabis education to the scientific and medical community, and also to support patient advocacy. One of my goals in life is to help change the world with education, and as I mentioned earlier, she has already done this. Plus, she gave me my big break on stage at Patients Out of Time. I can't thank you enough, Lynn. And then we have Andrew Mcintyre, who is a real pioneer in cannabis. He's been a caregiver and breeder here in Maine for decades. He's helped a lot of patients. He specializes in pediatric patients and very sensitive patients, very challenging cases. Very high quality medicine, pays a lot of attention to his work, and is really a pleasure to work with in collaboration. He shows up with his patients to their medical visits, takes notes. He's really goes the extra mile. And so I'll start with you, Lynn. The endocannabinoid system, in the work that you're doing right now that's relevant and important to you currently, how is the endocannabinoid system a part of that? How is that playing into what you're doing and what you're thinking?
Gosh, I'd say the biggest thing with that is it actually helps me try to feel like I'm not that crazy. You know, when you try to tell some healthcare professional, well, we've got this medicine and it can help for the nausea and vomiting. They also use it for glaucoma. The multiple sclerosis patient finds it really helpful. You know, I get to the third one or something and the eyes roll back and they're kind of like, it's okay, that's okay. And, kind of just think you're crazy. And this whole thing about the endocannabinoid system, it's like, wow, it is so pervasive. As Dustin said, it's throughout our body. It's so complicated, but it helps explain. There's a researcher in Italy, Vincenzo Di Marzo, who says the endocannabinoid system helps us eat, sleep, relax, protect, and forget. And basically, otherwise, he'll say it's almost involved in almost every physiological action in our body. So it is really important. I think the other thing which is confusing for us is these cannabinoids, endocannabinoids, are made on demand as we need it. And it'd be so complex to try to figure that out because this is on the cellular level, so you can kind of think things are happening all the time. And this system is responding to whatever stressors are happening, whether it be the environmental stressors, whether it be interactions with other people, the foods we eat, the toxins in the environment. This system's always interacting. So there's no way that we can go to the doc today and say, can you do my blood test and tell me how's my endocannabinoid system? Is it functioning well? But it also explains why the dosing is so different for people. Sometimes maybe it's just something to wake up your endocannabinoid system and get it working. Maybe you need to supplement it for the rest of your life. But to have this fantastic system that literally governs everything else, slows something down, speeds something up. Seizure disorders are probably another good way to think that. There's firing in the brain that is literally causing seizures. And the endocannabinoid system, understanding that, our cannabinoids can come in and literally shut that down, shut that firing too often to help with the seizure control. So it's something we need to learn more about the endocannabinoid system. As Dustin said, it's not in med schools yet. It's not in nursing schools. For nursing, I know that obviously better than medicine, but our state boards of nursing are responsible for making sure, giving the tests, the exams for nurses to get our license in the first place, and then they oversee our practice. So that if we have any infractions, they will discipline us and can put restrictions on our license or take it away. So we're in this flux right now, and I had the opportunity to speak with the state boards of nursing. They've got this council. And that was one of the issues. A couple of issues was, one, could you please start putting this in the exam about the endocannabinoid system? That might be backwards, and I don't think they're going to do it that way. But if you start testing for it, they will start teaching about it. This is important, and people need to know about this system. And then the other piece was, and nurses need to talk to patients. They need to be able to answer questions honestly when patients ask them. There are some hospitals out there that have literally had nurses sign a piece of paper saying they will not talk to patients about cannabis. And you just can't do that. I would hope the nurses would just refuse to sign it. It's just inappropriate. We need to be able to answer that. So we need this information so we can give patients good information. I could go on and on, but I think the biggest thing is it literally gives that explanation of why it works for so many different things. And the other thing is, and you can note on that we don't have many receptors in our brain stem, which basically controls our breathing, that's why people overdose on opiates. You take too much, it shuts down your breathing. Cannabis won't do that. So again, the body it's very complex. It's an amazing thing, and the endocannabinoid system, if we keep it healthy, I think that's the key to your health. As much as you can keep your endocannabinoid system healthy, it's going to in turn keep you healthy.
So why is it not in curricula yet? What can we do to get it there? I mean, I know this might be a frustrating question to answer because you've been working so hard on it, Marilyn, but what the heck is going on with the scientific acceptance of this crucial information?
Sad to say, I think clearly it's the federal prohibition. I mean, we're stuck here, and you'd think they would be ashamed. I mean, I don't know how the DEA and the Department of Health and Human Services, which advises our Drug Enforcement Administration about drugs in the levels, how they can with a straight face keep saying it has no medical value, it's not safe, it's highly addictive. It's like not one of those fits. I mean, when you talk about addiction, in addiction, we call it the exit drug because it helps people get off drugs of abuse because it helps put them back in balance. So it is very frustrating. I went to, well, for years I'd been going to the University of Virginia trying to get them to do something on medical cannabis, and they refused. We started Patients Out of Time. Our first conference, it took us 5 years to get an accrediting body to say, okay, we will give you the credits, meaning for healthcare professionals, that's a real conference, you know, they're going to present science. Our first one was in Iowa, Iowa City, Iowa, the University of Iowa, and only because Melanie Dreyer was the dean at the College of Nursing, and she's more or less my mentor. Melanie did research years back on pregnant women smoking ganja or cannabis in Jamaica, and was literally able to weed out the other factors. These weren't women on the bottom of the totem pole socioeconomically. These weren't women also drinking alcohol and taking a ton of other medications. They were choosing to smoke marijuana while they were pregnant, and she was able to follow them. And results were no permanent damage from the kids, no problems seen. But she basically went to the College of Medicine there and said, listen, if we can't talk about this at a university, where can we talk about it? And that broke the ice to get our first conference. And actually, our third conference did get to the University of Virginia. It's been an interesting road, I can tell you. That was 2004, our third conference. And when we had it there, I went back to them again, now that we had 2 national ones and nothing bad happened to where we had those conferences. So they agreed to do it. One of the leading pain doctors at UVA was willing to work with me on the conference. And so we got the School of Nursing involved, the School of Medicine involved, and we went to the School of Law. Because the School of Law at UVA has, Richard Bonney is one of the law professors, and he's been very involved in the history. He's got a great book out, The Marijuana Conviction. And it's a 1974 book that went over how that happened. It's a very interesting read, and that's when you find out that the American Medical Association was against the prohibition way back then, but they got overruled. But anyway, we had that because we said, the federal government's going to come after, is going to pressure you, and they did. So our third conference in 2004, we had it. 6 months before the conference, I said, can you start advertising? Let the people know that the conference, oh no, we can't do that. And what do you mean you can't do that? You do that for every conference, especially if it's a national conference, you put it out there. Oh no, we can't. And for the life of me, I just kept going around and they wouldn't, and they weren't saying why, they just said we can't. So then I'd go to the physicians I knew, I'd worked there for 18 years, and I'd go back to physicians and say to the leading pain clinic, can you get this to all the physicians in the pain clinic? Can you get this to the HIV/AIDS clinic? Can you get this to all your patients? And just went around there. Whether they were or not, we find out later that our own system in the university, as in many other systems, literally censor emails that have cannabis or marijuana in them. So whether they did or not, I don't know. It didn't get out. Our conference was successful. We had one person, one active staff from UVA come to that conference. The rest were so afraid, so intimidated, they didn't come. The good news is with 29 states, and back then people didn't dare say cannabis. You didn't dare talk about it openly. So the good news is we've got 29 states now, 8 legal, it's growing. We're talking about it, and that's what we need to do. And patients need to demand. You just need to demand. One of the advice I give to patients a lot of times is ask your physician if they know about the endocannabinoid system.
Yeah.
And don't just accept a yes or no. Well, what can you tell me about it? Do they know enough about it? That's a good start. If they say no, you can point them in directions of where they can learn about it. Our website, medicalcannabis.com, or many others. If they don't want to, find a new healthcare professional. Seriously, because if you've got a care provider who doesn't want to know about the endocannabinoid system, you don't want that person caring for you.
Thank you, Mary Lynn. And can you give us a couple details about this year's conference, or next year's conference?
2018, if anyone can come, and let me tell you, the way our conferences go, we do get more patients often than we do healthcare providers. But it'll be in Jersey City on May 10th through the 12th. It's a Thursday, Friday, Saturday. Thursday, just kind of some pre-conference stuff, and then Friday, Saturday. And we'll be bringing people from around the world, as usual. We try to bring the researchers who are in the field doing it, clinicians who are working with patients, as well as patients, and give that kind of full flavor conference. Thanks.
The Patients Out of Time conferences that I've been to since 2010, every one of them, it's just an incredible experience because it's a really rich mixture of researchers that are doing the basic science, of clinicians that are doing the medicine in the clinics, and then patients, patient advocates, lawyers, and just like a cross-section of everyone in this field coming together. Beautiful networking and brainstorming and problem solving that happens at Patients Out of Time. So I encourage you all to check it out. You'll leave with a great national and even global perspective. So Andrew, before I ask you any tough questions, I wanted to give you a chance to respond to any of Mary Lynn's discussion, if you had any comments or responses to anything there.
Well, my name is Andrew Mcintyre. I started in the program. I initially sort of came out of the closet from growing. I started growing when I was 9 years old. I had childhood epilepsy and autism, and between the plant and my healthcare providers, with my coaches, the people that loved me in my community and my diet, I was able to grow out of it. But cannabis was a huge part of it. So I want to say that I agree that the same thing with the endocannabinoid system and knowing the structure, it really helps me feel normal. I have the same clinical observations in it that Mary Lynn has. That I see so many kids come to me for epilepsy and autism, and they're all different. Sometimes I can select different cannabinoids for different seizure types or different diagnoses. But the general rule is that every child has a different body, and the actual ratios and types of cannabinoids that you use are most oftentimes different than they are similar in terms of like one condition or the other. So like as Dustin was talking about, is that the endocannabinoid system has to do with your personal body and not your diagnosis. What I like about that is that your diagnosis is not who you are. Who you are is your personality. When you have cancer, many times people put you into a bucket list and they say, well, you're going to lose your hair, you're going to do this. But everybody still is they're still their own unique personality. And having autism and epilepsy, I realized, how important it is to keep who you are. No matter what drug I have, I will always be an epileptic. I have a great life. I've had many great things, but you can't take the epilepsy out of me. I still have troubles. One thing I wanted to add to what Mary Lynn had to say about the study in Jamaica, I want everybody to realize this. This is in Martin Lee's book called Smoke Signals, or I believe you can Google it, right? It's a Jamaican study on women who are using cannabis while they were pregnant and or breastfeeding. And I just wanted to add, with those children, what ended up with, they did a cognitive development metric on them, and they found that the kids that the moms use cannabis actually learned language quicker and started social skills and cooperation.
And I just wanted to add that this is actually the rationale for most Jamaican women who are drinking cannabis tea when they're pregnant or giving the tea to their children. It's intentionally to make them smarter. And of course the tea is very low in THC, and so it's not going to get them stoned, but it's going to convey some of these neurologic development benefits. So absolutely.
Yeah, I think that's important to on that Jamaican study. Mary Lynn said that they were smoking, but what Dusty's talking about is that there's a cultural third world demographic where in the third world they still use cannabis the way that we used to 10,000 years ago. So those women not only smoked it, but they actually put oils on their vagina to open up the canal. They put it on their breasts. They put it into the spots that we're having problems with, and the children actually, when they were teething, would get the THCA resin on the mom's finger, and they put it on the mouth. All these are non-psychoactive. So there was a lot more stuff going on just than like a mom who was pregnant smoking a joint. She was rubbing it on her body, and it's a whole culture that we've lost.
And I just want to add that since that early work in Jamaica with Melanie Dreyer, there's been several cohorts of pregnant patients that have been exposed to cannabis smoke recreationally. These are not medical patients, just people that are so-called recreational users, and the offspring of these moms are in good shape. The one factor that seems to show up as a signal, and it's not in everyone, but there's a higher prevalence of lower birth weight for the baby in moms that are smoking cannabis. But a recent review of all that data done by our national government, the National Academies of Sciences, Medicine and Health and Engineering, they just released a 440-page report on cannabis this year, and they looked at this pregnancy data, and what they said was that it's almost certain that this lower birth weight, and I'm not talking about tiny babies, I'm just talking about a little bit lower, this lower birth weight is likely attributed to the smoke itself, not to the cannabis, because it's equivalent to a reduction in birth weight that you would see for tobacco smoking or other types of carbon monoxide exposure. So it's really not the cannabis itself. In other words, there's no detriment that we've seen that comes from using cannabis in non-smokable routes in pregnant women. And the one caveat might be that cannabis is a muscle relaxant, and even though it's great at helping with labor pain, and like Andrew suggested, relaxing the pelvic floor, helping the birth canal open up, it can also act as a muscle relaxant, which could slow down or decrease the strength of contractions. So in the time of labor, you want to use it in an intelligent way when it's needed, not just for everyone. So, okay, let's move on, Andrew. Okay. We mentioned THCA, we mentioned cannabis tea. In my world, you're one of the pioneers of raw cannabis use in this neck of the woods. I even brought a slide around to set you up for this topic. So I was hoping that you could tell us a little bit about your experience and recommendations with raw cannabis.
Okay, so in 1979, when I accidentally grew the plant, I thought it was some bird food seed, and then there was no tomato, I couldn't figure out what the birds were going to eat. It looked like basil, so I ate it, and then these migraines that I had from the seizures finally went away for the first time in my life. The pharmaceutical drugs wouldn't do it. They would just drug me, and I'd walk around the halls at school, and really I just was drunk. After later in my life being able to, try alcohol, it was very similar to what was going on with the drugs. So I actually ate the plant raw, so I actually got THCA. The reason why I'm connected to Jamaica and to Rastafarianism is because this is what the kids do. So it's normal in the third world to eat cannabis if you're a child. It's normal to make a tea. It's normal to have it in your mouth for your dental work, and that's their medicine. So today, so when I first came to Maine, I immediately started giving lectures because nobody knew what I was talking about. And I started working with Dusty with pediatrics, and so now we make like a ready dose infusion of THCAs so that we can have a talk about, like the doctor, we can dose and then take different children and we can get a guideline so it's dosed in a bottle. One of the things I wanted to make sure everyone understands is that while that's great for Dusty and I and for this whole scientific discussion, you don't have to do that. Like everybody in the state right now can grow 6 plants. So you have access to the most incredible medicine, and oftentimes when you use the acidic group, the doses don't have to be that specific, especially if you don't have epilepsy or a disease where,
And allow me to interrupt for one moment, just for those, because we didn't cover this in the basics in the introduction. THCA, that A stands for acid, and the acid form is present in the raw form of the compound. So when you have the raw plant, there's THCA, there's CBDA, there's very trace amounts of THC, very trace amounts of CBD. These compounds occur when the plant is heated. Now, 99% of the research we've done on cannabinoid compounds has looked at the already heated version of these molecules, whereas these raw compounds, the THCA, the acid version of the molecules, have very distinct and powerful therapeutic properties that have been researched very little, but have shown up clinically to be really helpful. And I'll let you take it from there.
I really was happy this year at the Harvard Medical Conference because Dr. Bonnie Goldstein and there was another doctor, Deb Kimless. Yes, they both did geriatric and pediatric. They showed THCA, CBDA, and they really started a great job of breaking down different formulas, for different age groups, and starting to get this thing going. I haven't read her book, but is that same data in the book?
I'm not sure, but I think you brought up a good point about everyone here having access to raw cannabinoids and to heated. Whether as long as you're 21, as long as you don't have to be a patient anymore in Maine. These compounds may have health promoting activities, right? Maybe more so than your broccoli or even your kale or cabbage that's growing in your garden.
Certainly.
How do you recommend people that are already healthy and maybe not specifically trying to fight epilepsy or migraine headache or some other condition, what would be your suggestion on how to use these raw cannabinoids?
Well, that's the interesting thing about when you're eating the plant raw is that it seems to me, in my experience, what I've seen is that the dosing schedule goes out the window because now it's a food and your body will break down the cannabinoids that you need from that food. So what's different when you have a heated, decarbed THC or CBD, these are made active by the person at the hot plate. But when you eat it raw, that is determined by the plant and your stomach and your body. You have a conversation with the food. In terms of medicine, it's important to have both things. And sometimes people that have cancer or certain illnesses, they need specific decarb molecules, and they need them to act fast. If you have an acute response to something, and sometimes you need a decarb, something that's going to be quick. You won't get if you eat cannabis, you won't get a quick response. But if you eat it over time, you'll see that it will start to modulate different parts of your body, and it's got things like vitamin K2. It's higher than kale, lots of chalcones and bioflavones related to green tea. So it's the diversity in the plant is amazing. But unfortunately, most of the time we smoke it. In Jamaica and in most of the third world countries, it's much more popular to make a tea out of it. But we're sort of cut off from that socioeconomically from that type of information.
Mary Lynn, do you have any comments on, as far as the medical community, the international research community, what's coming up on your radar as far as the raw cannabinoids?
Well, I know William Courtney, a lot of his work is outside the United States now in looking at it. Dr. Courtney with using the cannabis. But what was curious was our first conference in Iowa with Melanie Dreyer there was right after the Institute of Medicine came out with marijuana as medicine, assessing the science base. And she was brave enough to, thank them all for doing the study, the lead researcher there, but was saying, that's great, but you only looked at the research in the United States. It's very ethnocentric, which we are. I mean, a lot of the docs in the U.S., if it's not done in the U.S., it doesn't count. And that is crazy. I mean, Italy, England with GW Pharmaceuticals, the work they're doing, Italy with Vincenzo De Marzo, Spain with Manuel Guzman. Stuff's happening all over the world, and we do need to pay attention to that, which is why we try to bring it here. One thing probably, too, to talk about is Ethan Russo's, Dr. Ethan Russo, well-versed in cannabis, a pediatric neurologist, but he, back in 2004, wrote an article presenting the idea of an endocannabinoid deficiency, and he made the case that if you looked scientifically at looking at migraine headaches, fibromyalgia, and irritable bowel syndrome, you could see that they could show that there's a deficiency in someone's endocannabinoid system. So it makes sense to use cannabis. Well, 2016, he updated that article and added more things like multiple sclerosis, Lou Gehrig's disease, ALS, autistic spectrum disorder, post-traumatic stress symptoms. And that one I can understand that one. That's a big issue for me just because of the veterans. And if you think about a combat veteran and just being stressed, not just one time with one incident, but the next day and the next day, their system, which is trying to keep them in balance, is overrun. So I can even just see it in that understanding, not at the molecular level, but just looking at it that way, that it makes sense why the vets say, this medicine makes me feel normal again. I've had my first night's sleep. That eat, sleep, relax, protect, and forget, physiologically, women, it's helpful there in childbirth. You forget the pain so that you will hopefully have a baby again. But for veterans or for anyone with post-traumatic stress, sometimes those horrific memories are so bad, they can't get past them. And this puts it back there. There are things we need to forget. So it's this balance that works.
Thank you. All right, we've got about 7 minutes left, and one thing that I'm taking from this panel is that there's incredible complexity in the system. You alluded to it, Andrew, that there's so many different strains and types of cannabis with different ratios of these compounds, various dosages, heated or unheated. Every individual is unique. You're suggesting let a person's physiology have a conversation with an individual plant as it's being absorbed and figure out what to do. Now in medicine, typically practitioners like something where it's a single agent, a single therapeutic agent we can recommend, take X number of milligrams 2 or 3 times a day. And this is how do we come around to leaving our audience with some very simple tips? Because even though it seems like there's a lot of complexity in this, there's also some path of simplicity towards achieving good results with this plant without needing a sophisticated laboratory, maybe without even needing the help of any of us up here, something that people can do for themselves. I'll let you start, Andrew. How can we simplify this and empower our audience to do well with this medicine?
Well, everybody's heard the phrase "go low and slow" from Dr. Sulak, Dr. Umandabala, many other doctors. So the best way to do it is when patients come to me, I usually if I don't have a prescription from Dustin, which I always like because then it takes the pressure off me. I can just read his sheet and make the medicine, and it's good to go. But if I had to make the decision myself, what I'd start with is the lowest dose preparations with the highest possibility of things happening. So that would be like THCA is dosed 10 times less than CBD. And we start off with the easiest things that won't interact with other pharmaceutical drugs. If you come to me and you're on 16 pharmaceutical drugs, I'm going to go really slow. And chances are, if you come to Dusty, we'll probably have the same type of strategy. But I think if you're a home grower and you don't have a laboratory and you don't have access to milligram dosing, what I would suggest is to eat the plant as raw as possible. That means as it's living, to eat it right off, and then to try to have the way that you eat it off be the same every day. And seems to be what the body prefers, is that it actually is used like a spice in a spice rack. So that sometimes people get sick and they think that, well, if cannabis is good for me, instead of eating an ounce, I'll eat a pound. And it actually doesn't work that way. It's better off when you have really consistent, small amounts and quality is the main thing. And your body should respond. If you just eat 3 small cannabis tops like this, you should get an effect. If you have menopause or you have a migraine headache or some cramps or something like that, 3 tops should be enough to and it'll take about an hour. You have to give it some time. And you can't take cannabis and then get into a subway train and think that the cannabis is going to stop your headache. You have to take that and then go to a quiet place and you have to meet the cannabis where it's at. A lot of people don't do that. They want to just sort of force the situation, but your diet and your psychology and, you meet the medicine halfway and it'll work a lot better.
That's a beautiful comment. Thank you. To meet cannabis, find its meeting place and hang out there with it. How many people here have tried doing what Andrew suggests of just eating the flowers off their plants? Yeah, so maybe a quarter at most of the audience. And for those of you that haven't, if you have an opportunity to do so, I recommend it. The phrase, and I'm sure I didn't come up with this or even spread it, I learned it from one of my mentors in residency, Karen Gershman, a family doctor and geriatrician, and talking about the geriatric population, the elderly. She said, start low, go slow, and don't be afraid to go all the way. Because sometimes you really do need to go up to a high dose. Not everyone responds to these low doses, and that's important to keep in mind as well. Mary Lynn, what do you have to leave our audience with today as far as anything at all, but especially taking a very complex topic and keeping it simple in a way that's practical in their lives?
Well, I was thinking of one thing when you said about how do you start with someone. I do know there are some practitioners who literally will have patients come in and smell several different fresh buds and say, does one of them seem to really meet with you? I mean, you connect with it. And they'll start with that. Then along with that, the other story I like to always share is there's a woman, Kathy Jordan, in Florida, who in her 30s developed ALS, Lou Gehrig's disease, and she noticed she started dropping things and the symptoms got worse. And as she went to the docs and they were, well, you better quit smoking cigarettes. She was a smoker then, and this is going to be a bad life and you're only going to have so many years left. And she was just seeing this downhill, spiral, and had a couple kids. Her husband's a Vietnam veteran, did not use cannabis, didn't know about that. And so she was like, I'm not living like this. She started saving her pills. She's just going to commit suicide. Can't take it. She went to say goodbye to friends, and when she was down in Florida saying goodbye to a friend, she said, well, let's have a joint on the beach. You haven't done that since you've had the kids, And so they did. Random joint. She inhaled that, and she says she knew instantly. She says the humming in her body stopped, but she knew instantly it was helpful. She's now over 30 years surviving with ALS. When I first met her about 18 years ago or so, I had to stare at her when she talked to me to see if I could read her lips and understand her. Today, I can understand her. Her husband put the phone up to her, and I can understand her on the phone. I think she's 66 now or something like that. But she is just one force to be reckoned with. And I say that to people because it was a random joint someplace. She knew it was medicine. It took years then, a long time of trying different things. They found the best strain that works for her, the best variety of cannabis, and she uses that. So we are all different. Our systems are all different. This plant is wonderful, and you've said it before, you call it a very forgiving plant, but it's nothing so scary as, and I think as a nurse, that's, in hospitals, when I worked as a med-surg nurse years ago, you pass out meds. I mean, sometimes that's all we feel like we're doing. We have to get the meds out to everybody on time, the right dose, the right time, the right patient, the right route, etc. And you're doing that all day long, and sometimes you make a mistake, and it is very scary. It's really scary to think, I could have just killed somebody, or I could have done some really serious harm. And here's this cannabis, that fear's not there. I already said, if we take too much, not a good thing, and you'll know it. Patients will going to be really dizzy, might get really nauseated, but no permanent damage. So it's just, it's the kind of thing, I can't promise anything for people what it will do, but it's like, it's not going to hurt you. It clearly is worth a try.
Great, thank you. Well, that is all the time we have for the endocannabinoid panel. I'm sure my speakers and myself will be over here to answer more individual questions. Thank you all for your time and attention. It was really great attention today.